see how many. Okay, people are joining now. We're going to give just a minute for people to join, and then we'll start. I apologize to everyone. We're having a few technical difficulties with Anish. Did I see Anish? Great. Anish, can you unmute?
Yeah, my computer just fritzed, so I'm now on my iPad. So my apologies.
I'm glad it wasn't on my end.
Yeah, this is called an IT snafu for whatever happened, but I'm honored.
Great, fantastic. We're just waiting for the participants to join, Anish, and we'll get started in just a minute.
Sounds great.
Now, if you would leave yourself on unmute, that would be terrific.
Well, I got you covered. Thank you.
Wonderful. All right, let us start. First of all, I want to thank everyone for joining us this Juneteenth day in the hopes that we can finally begin to heal, celebrate our diversity, and truly become one nation, indivisible under God. And Anish, if you can unmute yourself.
There we go.
Great. My name is Michael Cook, and I'll be your moderator for today's Healthcare Forum, which is part of our DemBiz Signature Breakfast Series. I'm a member of the board of DemBiz and also a practicing attorney in the healthcare field for more than 40 years and chair of the board that oversees Virginia's Medicaid program. We've got a terrific panel with us today to discuss our topic, the impact of the coronavirus on the status of healthcare currently, how it's going to change healthcare in the United States going forward, and its impact on business and the economy. I need to use up the entire time if I were to tell you the entire bios of our three panelists, so I'm going to abbreviate them and apologize to them if I leave something important out. First, we've got Dr. Jennifer Lee. Dr. Lee is currently a clinical associate professor of emergency medicine at George Washington University and a visiting scholar at the National Academy of Medicine. She also serves as a medical analyst for CNN during the coronavirus pandemic. And previously, Dr. Lee's held a number of government positions, including being the director of Virginia's Medicaid program during the time that we expanded Medicaid. She also was the deputy undersecretary for health policy and services at the Veterans Administration in the Obama administration, and deputy secretary of Health and Human Services for in Virginia for Governor McCall. Next, we've got Dr. Bassem Khan, who is currently the executive director of Neighborhood Health, which is a federally qualified health center that serves approximately 30,000 mostly low-income, uninsured, and underinsured folks in Northern Virginia. By the way, for what it's worth, it is an absolutely fabulous healthcare program that Dr. Khan runs that takes care of basically our most vulnerable folks in society and in Northern Virginia. In addition to being a physician, Dr. Khan also has a master's in public administration from the Kennedy School of Government at Harvard and has served on the boards of the National Physicians Alliance and on the Governor's Council of the American College of Physicians. And finally, we've got Anish Chopra, who is currently president of Care Journey, an open data membership service for physicians, healthcare networks, and healthcare facilities. Anish has served as the first chief technology officer in the Obama administration and as Virginia's Secretary of Technology under Governor Kane, and he now serves on the boards of the Healthcare Cost Institute and the New Jersey Innovation Institute. And Anish also has a master's from the Kennedy in public policy from the Kennedy School at Harvard. In short, and from personal experience, each of these panelists are an exceptional group to speak to us today. Let me begin we will begin, and a little housekeeping here. We'll begin by having each of our panelists give an particular area, and I'll ask a question to start that. I'll also ask a few questions of them after that, and then we'll be taking questions from our viewers. You can ask a question by hitting on the Q&A box. I'll choose from them to present to the panelists, and please include your name, if you would, when you're asking questions. We'd also like to recognize one of our board members, Carlos Del Toro, who's a benefactor to the organization And finally, before we begin, I would encourage any of you who are not already members to join DemBiz by going to our website at www.dembiz.org. All right, let me start with Dr. Lee. Dr. Lee, could you address what the COVID pandemic is and frankly, how you see it affecting healthcare overall?
Sure. And first of all, Michael, thank you so much for having me. It's a pleasure to be with you all this morning, especially with two wonderful friends and former colleagues, Basim and Anish. And I just want to say, I got to give you a special shout out, Michael, because as you mentioned, you know, we had the opportunity to serve together when I was the director of the Virginia Medicaid program during the exciting time of implementing Medicaid expansion. And I so appreciate, Michael, your service, your support, your advocacy, and expertise. And so glad that you are still there as chair now of the Board of Medical Assistance Services. So thank you for your service to the Commonwealth.
Thank you.
Absolutely. So there's so much we could talk about, but I think I'll just mention a few things, and then as you said, we can get into Q&A later. So, you know, how has the COVID pandemic affected healthcare? You know, what areas has it not? You know, I'll talk about, you know, three different aspects of this, some that I've reflected on from the policy perspective, and some is just being on the front lines of the pandemic during the last few months in the ER, and also working in two different systems. I work at George Washington University in DC, also as part of the Kaiser Mid-Atlantic here in Northern Virginia too. So it's very fascinating to see two different perspectives during the pandemic. So, so first is, I think, what the pandemic has revealed about our public health system, you know, in the United States. And that is that, you know, for truly decades now, we really have neglected the proper resourcing and support and infrastructure needed to have a strong public health system to be able to respond in times of crisis like the COVID pandemic. And this might be obvious to some of you, but I thought it might just be worth saying that, you know, our public health system really is a separate system from our healthcare delivery system. Just the healthcare that you and I think about when you're going to see your doctor, going to the hospital, getting medications filled and such. The public health system is run, of course, by state and local health agencies. And the purpose is really to protect the public, to prevent, to focus on prevention, preparedness, and surveillance and response. And it takes resources to do that effectively. And I think what the pandemic has revealed is that over the last, it's really been decades, but especially the last 10 years, slowly over time, we've really neglected the proper resourcing in the public health system. So we weren't able to have the appropriate surveillance, investigation, coordination, education that we needed to have, despite the very hard work and attempts of all of our public health leaders. The resources just need to be there. And of course, this was compounded by the lack of strong science-based leadership and communication and coordination at the federal level. So one of the things I think that we should hope to see and that we need to see is a change in how we fund public health and an injection of funding. And we've seen some of that in some of the emergency funding that Congress has passed to respond, but we really need to see much more. So second is kind of on the healthcare delivery side, and is what's happened, and this is while being in the front lines, it's felt a little paradoxical. You know, the fact that what's happened is at the system level, in order to respond to the pandemic and a potential influx of cases, the health systems delayed or canceled a majority of elective procedures, surgeries, and of course a lot of outpatient visits. And that was very appropriate because we didn't know what the volume of COVID patients is going to be like in the various areas across the country and in Virginia. And we needed to conserve, make sure we had enough staffing, space, as well as personal protective equipment. So it was very appropriate to do that, but what's happened as a result is a dramatic hit or drop in revenues to many hospitals, systems, and also practices. You know, just if you look at surgical admissions, even though they make up only a quarter of hospital admissions, they account for at least half of revenues. And so to see those dramatically drop, except for just the emergency ones, has really hit a lot of the systems hard. And that's why you're seeing, you know, the last number I saw is about 1.4 million healthcare workers furloughed or laid off in the last few months. And a lot of hospitals really suffering financially. And that's unusual because usually healthcare has been very resilient or immune to economic recession. So that's been a major hit, and we'll have to see. There's some relief that Congress has appropriated, but we'll have to see what happens long term. Last thing I'll just mention briefly, and I think Anish is going to talk about this too, is what I think is a good thing, and that's been this dramatic rise in the use of telehealth. So as we've had to really decrease the amount of in-person visits in practices, in outpatient settings, and inpatient as well, telehealth has become this, use has increased significantly because patients and providers had to, of course, have some ongoing interaction in healthcare. And in some systems, and it's felt this way in one of the systems I work in, it's almost been a flip from 20/80 virtual to in-person to 80/20 telehealth to in-person afterwards. And then also, of course, that's been helped by a lot of the flexibilities, emergency flexibilities, and changes in payment that were put into place at the federal level to finally reimburse a lot of the telehealth visits at a comparable level as in person. And I think the response has been very positive. A lot of patients are very happy and find it to be convenient to be able to have a virtual telehealth visit rather than in person. So those are just a few. There's so many things we could talk about, but I'll just stop there. Turn it back to you, Michael.
Thank you, Jennifer. Thank you. Dr. Khan, we know that the pandemic is having a disproportionate impact on indigent minority communities. How are you folks handling that, and how is it affecting your patients, and how are you handling the very, very difficult issue of the impact of the pandemic on your folks?
Thank you, Michael, first for having me on and for your support for our organization over the years. And it's great to be on the panel with Jennifer and Anish. You're absolutely correct. We've seen this across the country, and we've seen it since the beginning of the pandemic. You know, when we were looking at data coming out of New York in the early days, we saw that the boroughs or zip codes where they had a high percentage of low-income and minority patients, the percent positive coming back from those zip codes were higher than in some more affluent areas. So we thought that we would see the same here in Northern Virginia. And when we started testing around early April, we began seeing that immediately. So our patient population, which, as you mentioned, is primarily low income, a lot of immigrants, minorities, uninsured or underinsured, were testing positive at a rate of around 50 to 60%. And that, in comparison to Northern Virginia at the time, that was twice as much. So Northern Virginia's percent positive rate was around 20 to 25%. And at the time it was below 20% in the Commonwealth. So our patients were testing positive at twice the rate as someone trying to get a test in in somewhere else. And, you know, most of them were Hispanic. So our patient population is about 50% Hispanic, but our COVID-19 patients are approximately 90 to 95% Hispanic. So just to give you a sense of how the pandemic has disproportionately affected that population here in Northern Virginia. So it's a national problem, but it's also a problem right here in Northern Virginia. And the reasons for that, I mean, I think are simple, right? They're at higher risk because of the economic pressures that they face. So when you don't have the option to work from home or to take paid sick leave, or just to take time off of work because there's a sense of job insecurity as well. Even if they take 2 weeks off, the question is, are they going to be able to return to work after they're done? So with that, people are going out in the world, they're unprotected. Employers, I don't think we're doing a great job, especially early on, for protecting their staff. Public transport, living in crowded conditions. We've had some patients who we've been trying to tell them to isolate once they get diagnosed, but they actually share a room with 5 other people. Some people who are not even living in who are in their family as well. So for so many reasons, primarily economic, they're at a much higher risk of getting infected. And then once they do get infected, they're in a challenging situation because the loss of income that comes with not being able to work is much more difficult on them than it would be for other people. So our patient population has been significantly affected. We've done probably 2,500 to 3,000 tests so far, and half of those patients, or at this point it's a little lower, have tested positive. And so we've done, like a lot of other places, we've done a few things to be able to support them. First of all is trying to get testing out there in the communities that need them most. We've seen data, this was out of Chicago or Illinois, that in the neighborhoods where you had higher percentages of low-income people or minorities, the actual testing availability was lower. So here in Northern Virginia, we've tried to do the opposite. We want to make sure that we actually target the people who are most likely to be impacted. So we've set up 5 testing locations. They're all in areas that are accessible to our patients. And I would go as far as saying that being able to access testing as a neighborhood health patient is actually easier than accessing testing with probably any other system. Initially we were we were saying you needed to have symptoms to be tested, but our threshold was actually lower than most other places. Even a patient with a sore throat, we would be able to test them. At this point in time, for our patients, we're not even requiring symptoms. So for people who are already our patients, if they want to get a test for whatever reason, we'll just test them because we want to make it as available as possible. But testing, there's been a lot of focus on that, and it's obviously important. That's obviously one piece of the response. The other is trying to support them clinically, even though there are no treatments at this point in time, although there are certain things being studied in the outpatient world. We're trying, we check in on them, we're calling them regularly, giving them whole pulse oximetry machines when it's needed, delivering that to their houses. The other really important piece is being able to support our patients, because a lot of times you tell them to isolate or quarantine, but they just can't do that, right? If you tell them take 2 weeks off of work, obviously if they have COVID-19, they're more likely to do it. But for their contacts, the quarantine, they choose not to do it. And a lot of that has to do with income, with food. So it's connecting them with resources. We've been working with nonprofits and our local agencies to be able to make food deliveries for patients who really need them because they're not able to get out there and get food. And then the other is sort of the public health piece of this, as the health departments are sort of ramping up their efforts. And there are 2 things that I wanted to quickly highlight. First of all, contact tracing, as you know, is sort of a linchpin of being able to control pandemics like these. But the problem is here, this blew so out of control that our local health departments did not have the staffing to be able to manage, to be able to actually do contact tracing on this scale. So for our patients, we set up a program internally and tried to begin some contact tracing with them. Like a lot of healthcare organizations, we had to retool. So people, who were in the dental department, for example, we trained them as contact tracers to be able to help with that. Now that the health departments have begun ramping up, we're beginning to pull that back. And the final piece, which is, we noticed there was a difficulty with our patients being able to isolate at home, as I mentioned. So fortunately, the local jurisdictions, Fairfax County, Alexandria, and Arlington, have made hotels available for people who want to isolate outside the home. So we've been able to coordinate that with some patients. Most choose not to do that because they want to be home for obvious reasons, but some who do want to be able to isolate and are not able to do so at home, we have been able to place them in hotels. So it's a pretty broad approach, getting testing out to the communities who need them most. We're actually looking into a mobile testing unit at this point in time, being able to support them clinically, primarily through telemedicine, and I can talk about that later because we also had to shift. And then a lot of support with food, masks, other resources, and trying to help them isolate in hotels, and be able to be happy to talk about any of that in more detail later on.
That's great. And thank God for neighborhood health and your leadership. Anish, could you talk a little bit about how do we get the economy moving again, open again, as well as a little bit about, we've heard a little bit about what the the pandemic is doing to the way we deliver healthcare, but a little bit more on technology, if you would, as well.
Yeah,
And it's
thank you, Michael, and echoing Bassem and Jennifer's thanks for being on a panel of friends and on a topic that's incredibly important. So thank you. Michael, I begin by saying that we took a blunt instrument to the crisis because we didn't have much of a choice. Shutting down the economy to give us some, basically to flatten the curve so that we didn't overwhelm the healthcare delivery system. And truthfully, as painful as it was a necessary step to lock down. And we have successfully flattened the curve. And I'm very proud of the work that been, public sector, private sector folks came together to operationalize what was obviously a difficult thing to do. As we begin to reopen, one of the most important things that we're going to want to focus on is how do we instill a sense of trust in the Northern Virginia economy? That is to say, even if Governor Northam announces that we're all good, whether he does another delay or not, independently of a political action, how do people in the neighborhood feel confident that they can go about some role in the economy? And I think to get that right gets to the question that Bassem just touched on, which is to have more confidence in whether or not we've got, from a blunt instrument to more of a surgical intervention, the ability to identify hotspots. So Michael, we now know that nursing homes have been an terribly tragic source of this pandemic in terms of case volume and the case volumes that relate to more chronic condition or morbidity and mortality statistics. And so being able to be more granular and understanding about where the next hotspots are, it's the analogy of saying, can we put out small campfires by identifying them early and then manage them thoughtfully with contact tracing, identifying through testing who's got the condition, and then managing their health status safely at home or quarantined, compared to the wildfires that we were seeing early days in the pandemic. That means we've got to get a couple of these key variables right. One, we do need to ramp up. By the way, testing has ramped up. I think Bassem's comment that now we can do anybody, I think is an indication of where a month ago we would probably say it was more of a constrained resource. Now we've got more capacity. So that's great news. Tracing is an area of concern, Michael, because just because we've got the test, how quickly does public health respond? I will use this as a segue into probably the risk factor, then I'll get into technology. To me, the biggest risk factor is just our inability to share information, complete information between the testing sites, the public health agencies, and some of those frontline providers like Bassem's described that are capable of helping augment the staff that are understaffed on public health. Today, half of the cases that are submitted to public health nationwide lack any demographic information, race or ethnicity, 50%. Hardly any of them include details about the patient's chronic condition status. Are they in a nursing home? Are they a healthcare worker in a high-risk environment? So in the CARES Act, Congress called on every lab conducting a test to put together a minimum data set, who the doctor was that ordered the test, what the patient's actual phone number and address is, obviously their test results, but then answering basic questions about their risk status. And we now have an August 1 deadline for the testing systems to comply with being able to assemble all of that information. I am not very confident, Michael, we're going to have the kind of robust information sharing that we're going to need in order to get the job done. The accuracy on phone numbers and addresses is so poor. How are the contact tracers supposed to do their job if they don't have a place to call? And anecdotally, people can go days without getting any phone call from a contact tracer. And so each of those days, that's a self-inflicted wound for economic recovery, our inability to do the surgical intervention. So I would hope, I serve on the Go Virginia, Northern Virginia board. I'm hopeful we can do more public-private collaboration to keep this surgical testing and tracing model in place, but it's not, I would not say that we've solved that. We've got to continue to be vigilant about it. Having said that, I will say there are some positives that are going to come out of this crisis. I do think Virginia had been a leader in authorizing telemedicine and to think about medicine as medicine, whether you're having a video conference like we are today, or we're physically in the chair or on the table in front of a physician. We should be able to understand that in today's environment, a physician can synchronously or asynchronously communicate with patients, get the information they need, render decisions, and execute a care plan. So we are now seeing the culture change that the technology and policy frameworks allowed for. And I'm not sure, and the big policy debate coming out of this is there going to be a new normal where healthcare costs just come down a dozen points because a lot of the care that was previously delivered was unnecessary or could have been handled in a different way? When we emerge, will we see a snap back to the same level of healthcare utilization, or will there be some middle? And I'm of the view that we're going to see some movement on removal of unwarranted variation. This was a major Obama administration initiative to drive to value-based care to reduce unwarranted variation. And if there is a positive, I do think it's the enablement of these wider ranges of communications tools that would allow patients to safely access the healthcare system, and hopefully a new model of care delivery that will result in a lower cost healthcare system. So as those of us in this community want to expand access to everyone, and Jennifer, great job on Medicaid expansion, if we can bring down the rate of healthcare inflation, we should theoretically help to move more of the universal access policies and really get the system under control. So Michael, that's how I would view it. We've got work to do to give confidence into the local economy that we should get back moving again. We've got to nail the contact tracing and the data aspects of public health communications. And we've got to keep an eye out on the new models of care delivery that will emerge, that will keep costs down and quality up.
Following up on that, with contact tracing especially, there's been some suggestion that one way we get better contact tracing is through using technology such as cell phones to monitor where people are, and that's created a major debate in our economy and in the public eye. I want to go around the table if I can a little bit and just get your views. Each of you, especially Bassem, you work with a very different patient population. Jennifer, first just a brief response from you, and then we'll move around the table on that and how you see that rolling out, or whether you see it rolling out.
I think that it could be digital solutions such as the one that Apple and Google developed together. I think could be very helpful. It's interesting to see how other countries used cell phone and other digital technologies to help them with contact tracing. Not only did they expand their workforce of contact tracers, but they used surveillance and cell phone information to figure out who people had been in contact with. So it makes the process much faster. And when you're dealing with a virus that can be transmitted so quickly to people who may not even have symptoms, for a while, they don't even realize they're infected. It's very helpful. The question of, it's really more a question of will people feel comfortable, and are there enough privacy protections in place for people to adopt or to feel like they can use those solutions. So I think, if it's one tool in the arsenal, I think that it's very helpful. I don't think we should go with a sort of single-minded approach, just the traditional way of the human contact or just the technology solution, but really use all the tools that we have. And just as Anish said, because part of the problem is that we've had, and Bassem said this too, we just don't have the workforce right now. We've lost at national level about estimates are about 50,000 people in the public health workforce over the last 8 to 10 years or so. And you can't make that up overnight. It's very difficult. So you need to look at creative solutions. I think that it's something we should have in our toolbox.
Awesome. Is that going to work in the populations that you serve, especially the homeless population? How do you contact trace there?
It's a good question, and I think the concerns about being able to use technology in certain populations is valid. You know, the issue is one of trust as well, and that's something that I think the whole contact tracing effort needs to really take into account and is taking into account, because a lot of times patients, for example, if you're trying to reach out to them by phone, they might not answer their phone, or individuals might not answer their phone. Are they willing to give information out? Are they, you know, willing that they feel is private? Do they trust the person on the other end of the other line? There's the issue of the government calling you potentially, especially for certain populations, undocumented folks, for example. So, you know, I think different populations or different people, different things will work for them. And you know, my sense is that it's a, you know, try everything approach, because, like, you know, Anish had said, the issue of speed is really important when it comes to contact tracing. You want to be able to reach out to them, you know, literally as soon as it happens, and try to get a hold of people really quickly, because as we are seeing, the transmission happens in the earliest days, and frankly, even when people are pre-symptomatic. So a lot of the times, by the time someone's on the phone doing contact tracing, might already be too late. So when speed is such an important factor, and when there's certain populations where technology may not work, it's one of those try everything approach and then see what works. And I feel like our response in general to, you know, emergencies like that should be, you know, throw the kitchen sink, frankly. So if technology can work and it does give you an opening, by all means, I think it should try it, and then it should be tried, and then we should learn from our experience. But definitely in certain populations, obviously homeless people, a lot of immigrants, lower income people, there sometimes is no substitute for someone calling you and speaking to you and then building that trust with someone.
Yeah.
Anish, what do you think?
Well,
Yeah, go ahead, Anish.
Yeah, I'm going to just take it. I'm going to double down on the comment that I think Jennifer earlier said 80-20, 20-80. I think this idea of the Apple Google phone solution is the small minority of the incremental lift for what we need to do this well. And I'm one who's obviously pro technology guy, so I don't want to. I want to be more on the, you know, this is not the problem to solve immediately. This is supplemental. I've got a more fundamental problem, and that is if the phone numbers are not accurate and the addresses are not accurate coming into public health, period, we can't do anything right. And as of today, I have very low confidence that the information coming in is sufficiently accurate to feel like Northern Virginia is going to come at this strong on the surgical approach. We ran an experiment. I volunteer for the city of Chicago Health Department because the leadership there said they are absolutely frustrated with the inability to get accurate information. Again, I mentioned to you, 50% of the cases don't have race or ethnicity recorded, and if they do, it may not even be accurate. So what they had done in Chicago was they deputized a local health system to basically, you know, we spent $40 billion, Michael, investing in electronic health records, and yet we're still relying on 30-year-old interfaces into public health. It's as if the $35 billion investment just completely poofed and didn't do anything for public health. And I know that's not technically true, but it feels like it right now. So just by connecting electronic health records to the lab results, the lab feeds, the completeness rate on race and ethnicity went up from 50% to 85% overnight by integrating the two data sets. And as I look at the requirements coming out of Health and Human Services on accurate phone number, accurate address, I feel like we're going to have to do more to complement the existing data infrastructure. We're not going to rebuild IT for public health in 2 weeks. It's unrealistic. So we're going to have more of an integrated approach. And that to me means if I were going to go to consumers about helping to make this thing work better, I'd be much more interested in having them complement the lab result with accurate information about a survey that they could complete about their risk factors and have that combined information go to public health. So Chicago is contemplating a relationship where consumer-facing or physician-facing applications can supplement, almost like a survey, what's captured in the official lab results, and that the combined information can be sent to public health to manage in contact tracing. So to me, I want to solve the problem, inaccurate information, which weakens our capacity for contact tracing, coupled with the reality that we're going to have many, many more contact tracers on the books of public health. And even in Basim's case, and Jennifer mentioned maybe some alternatives that can expand it. But we got to start with accurate contact information, or else we're just going to find ourselves, 4 days behind with, exponential risk of exponential spread. So, and I'm also worried, Michael, to make another related statement. Jen, you tell me, how many high-risk patients have gotten the flu shot last year? And it's probably 50% nationwide of seniors get the flu shot. I don't know how many that you would deem high risk, but can you imagine if we didn't get everyone the flu shot this fall, the double whammy of wave 2 combined with people showing up in the ER with flu-like symptoms? How much PPE are we going to burn? How much waste in the system? I am fearful that if we just sort of treat this year's flu like the flu and we don't take it seriously, we almost have to have a universal flu vaccine campaign to kind of minimize the fear, the risk on the. I'm going off topic, but I'm curious, Jen, how you're thinking about that, if you don't mind answering it.
Well, I'm worried about it too. We're definitely not ready for that. We have struggled to just kind of keep up on the acute care side with the COVID patients right now. And the whole question of personal protective equipment, I mean, we could talk about that for an entire hour alone, has been such a challenge. And I don't understand why we didn't get a stronger and more proactive federal action and leadership on this, because it could have been solved. We still don't have enough right now to be doing what we really need to be doing. Basim and any healthcare clinical provider knows that the standard that we used to hold to before we got into this under-resourced situation is that we would change and throw away this equipment after every patient interaction. Mask, gown, gloves, everything would just be tossed in the trash. And now, of course, to this day, when I work an ER shift, I'll get an N95 mask and I wear that one mask for the entire shift with every patient. I take it off maybe once in 8 or 10 hours to drink something. And of course, that's a difficult way to work, but it's also just not the way it's not the standard that it's supposed to be. So why didn't we solve this problem? I mean, again, I could go on a tangent on this too, but other countries, Taiwan, South Korea, many countries saw this problem coming and they ramped up domestic manufacturing because they also were sourcing a lot of their equipment from China. China was the #1 manufacturer of masks, of a lot of this equipment. And so they had the same problem we did. And yet within just a matter of weeks, they were able to quickly ramp up their domestic manufacturing. And we, though we did some efforts at that, chose not to, the federal government really, and the White House chose not to use every authority they had in order to make that happen. And that also comes into play with a lot of the other measures we have to take, because if you don't have PPE, you can't protect people in nursing homes because you can't get it to their staff. What about the people going into the home health workers who still don't have enough PPE today? I mean, this is still a problem we're facing now, unbelievably. So, again, we could talk about that for hours too, but we are not ready. And it is a big concern what will happen this winter when we have flu coming as well.
Yeah, and I want to move to some questions from the audience, but I also want to make one quick comment on PPE. Nursing homes were promised a certain amount of PPP coming through a while back. What we're hearing now is that what they're getting is incredibly deficient. Some of the masks, these are anecdotal reports, but they've been written up. Some of the masks are appear to be from cut up underwear. Some of the gowns appear to be trash bags being cut up. So we're still behind the curve on that one. In probably in your petri dish of nursing homes for the coronavirus. Let me go to a couple of questions from the audience here, if I could. First one is to Bassem, I think, although all of you can comment on it. How does climate change influence COVID-19 in health, and how do we make the public aware that climate change is really a public health issue as well? It's a little bit off of COVID.
Yeah, I think the way that I think about that is maybe a little different than the way the question was framed. Is, what this crisis has shown us is an incredible lack of resolve. Just thinking about PPE, is one really good example, and imagination. And something that a lot of experts have been warning for years, that, a pandemic, in the case, it was often said pandemic flu would have such devastating impacts across the world, something that people in a lot of industries knew about. And yet when it finally came, things broke down at a very basic level. And, months into the pandemic, I still see an incredible lack of imagination and an incredible lack of resolve to do the very basic things. And PPE is one good example. And there's so many other pieces to this. And I think that's a really, if there are any lessons we should draw from this, I think a lot of them do relate to climate change, where, people have been talking about this now for decades to some degree. And yet there's the degree of resolve, the degree of denial, and just the lack of imagination to move us forward has been stunning. And I think that's sort of the parallel that I think about. That's something that's not even a far time away, something that has really impacted us so deeply in so many fundamental ways. We still haven't mustered the type of resolve and collective action needed to overcome it in this country, where there are other countries across the world that have done a much better job than us. So it's not even that it's impossible or that no one else has done it. And that gets me even more worried when it comes to climate change. I mean, hopefully we draw some lessons out of this.
And by the way, I neglected to mention that question came from Joan Schiller. Another question comes from John Cartmill, and that from Herndon, and that is, what does the panel think the effects of the pandemic will be on medical insurance rates? And I think we've seen some of that, but Anish, you want to jump into that one?
I think insurers have already begun announcing that they'll be offering some type of rebate, and Jennifer will correct me, but there's been some sense that to meet medical loss ratios and rebates, there'll be some savings. No one can truly understand the COVID particular cost implications, because that one remains an open question. I'm worried that we're seeing some on the employer side in particular, an unwillingness. So Bassem described doing testing for everyone. I'm a little worried that for the employers that have self-insured plans, they may not be that keen on just willy-nilly funding testing, especially with some of the shady behavior of labs that have charged thousands of dollars, per test. So there's the overall medical trend, which I think is going to go down. The question is how far. And then there's the COVID specific circumstance, which, we don't even have clear protocols as to who should be proned and ICU admission status and some of those issues. And so I think the COVID book is unknown, but the overall trend should go down. Jennifer, you probably have a better judge than I am on what you're hearing, and even on the Medicaid side of how would they be thinking about it.
Yeah, and I didn't know if the question was about how the insurance industry was going to do, or about how coverage was. So wasn't sure which way specifically the question was going, but I agree with you, Anish. And we've already seen too that some of the big insurers, especially those who are primarily in Medicare Advantage or Medicaid markets, which are mostly more and more capitated now, did really well over the last few months because, again, that utilization went down. People did not get the care that they normally would have. They didn't have as many visits. They didn't get the procedures done. They didn't go get hospitalized for things that, and some of that is good. Some of the care, Nishi mentioned this earlier, was unnecessary, frankly. And I hope that we too can get a rebalancing to truly get closer to value-based care, that really paying for the care that matters for people's health. But some of the care also needed to happen and didn't happen. And we saw, I've seen that personally, and my colleagues have in the ER, where people delayed care or just didn't come in and had bad outcomes at home. Stepping back out, what that meant is, again, that on the provider side, practices, hospitals, health systems suffered financially. But on the insurer side, again, especially in those markets where they're mostly capitated, they did very well and had more profits, more revenue. Some of that they gave back and had to redistribute. So it'll be interesting to see what happens. And then if the question was about coverage, very concerned about that for people. There's we're continuing to have a lot of people, filing for unemployment, losing their jobs. We still have primarily employer-based insurance, and it leaves a lot of people in very desperate situations. And if they're in a state like ours in Virginia, where we fortunately have expanded Medicaid, hopefully there's an option for them. That still excludes a lot of legal permanent residents, even in Virginia. But there are many states with large populations, like Texas for one, where I really worry about people who've lost their jobs and really don't have much recourse in terms of insurance. And what we're seeing now, we look at the latest trends in terms of, as we're the healthcare, the practices and appointments are opening up, are people coming back. The rebound in use and utilization has not been as fast or as high as predicted. And some of the thinking is that behind that is that people are concerned about cost. I mean, this was, before COVID, the number one domestic concern was the cost, affordability of healthcare. It's still there. We still have this problem. Hopefully, some of the disruption due to the pandemic will help us to address that. But I think people are still delaying not getting the care they need or not getting procedures, medications they need because of cost. And it's going to be worse as they lose insurance coverage.
Yeah, and I think just a comment from one of the things that I think scares or ought to scare a lot of us, while the insurance companies are spending less because people are getting less care, some of the stuff we've discovered in delivery system reform is that a doctor's visit or a lab coming in at the right time for a chronic diabetic, for example, at the right time, can make a difference in cost and in overall health. And to the extent that we're not delivering care that can reduce costs and improve health, some of the preventive work, that's got to be scary in its own light, and obviously something we're going to have to deal with in the new normal. One of the questions that's come in from Lauren Hershey, and I'm going to paraphrase this a little bit, but is that we've seen Senator Kaine, for example, discovering that he and his wife have got tested for antibodies, and at least that test showed that they had antibodies. But we're also hearing about the aberrations in antibody tests, how long they last, and things of that nature. Dr. Khan, can you talk a little bit about that? what one expects to see on antibody tests, how accurate these are? Do we know anything about them?
Yeah, so just the basics. I mean, most people probably know this, but when you test for an antibody, generally it's looking for a past infection. Have you had an infection and recovered in the past? And there's a lot of interest in that because people may have had an infection, or might have had symptoms that they thought was a COVID infection, not got tested, and then later on they want to see, well, did I have this in the past? And the assumption being that if I've had it in the past, I have antibodies and thus I have immunity and perhaps I'm safer or more protected. The challenge, however, is that, the way that, you need to be fairly certain about the accuracy of the test. And when you have something that is low prevalence, which in the case of COVID-19, despite all we're talking about, the prevalence of it is still fairly low. So the majority of the population has not had COVID-19 at this point in time. Even in New York City and some of the most affected area, that if we're there, it's 20%. In other areas, in this area, I would suspect it's more along the line of 2%. So anytime you're getting a test where only 2% of the population has had what you're looking for, there's a real possibility that they're false positives. In other words, if 4 tests come back positive, there's a real possibility that 2 of the 4 are false positives. And if you're looking at this testing as a means to say, quote unquote, you're safe, I think that can be dangerous, because if you have a false positive. The other question is, what do antibodies even mean? Does it mean you're immune? The answer is probably yes, but I think the jury's still out to some degree. How long does immunity last? Is it a few months? Is it a few years? And I think some of those questions are still out there. So, that's why one should be cautious when it comes to antibody testing. There are certain ones that, are more accurate than others. So, if one is really interested in it, to do research in that sense. And then the other piece is that we're sort of looking at from our operations is we've gotten requests for antibody testing, but at this point in time, we're choosing not to do that. And the reason we're not doing that is sort of a question of where's your focus? Is your focus on diagnosing past infections where the utility is unclear, or is it diagnosing current infections? The other reason we're choosing not to do it is because that, I think, will drive more people into the clinics at a time where we're trying to keep people out of the clinics. So that's just a small logistical item from our point of view. But once it gets to the point where, they are more accurate and we have more of a regular flow, then we would start doing them. I know LabCorp and Quest are offering it as well. What we are participating in is a research study with Innova and the Virginia Department of Health to look at the prevalence in different populations. And of course, our patient population is really important in that respect. So people are already coming in for blood draws in 1 or 2 of our locations. As part of this research study, we are offering them antibody testing as well.
We have only about 5 minutes left. I've got one question here that's fairly simple, I think, to answer. Back in March, it was taking up to 2 weeks from Elizabeth Flashner. It was taking up to 2 weeks for a COVID-19 test result. What's the average time for getting results back now? And just as an anecdote, I got tested fairly early and I was told it would take 10 days to get the results. And I mentioned to my doc that by the time we got them, if it was positive, I'd either be dead or cured. She thankfully said, I'm hoping for option 2. After about 10 days of self-isolation, my family may not have gone for the same vote. But how long is it taking now to get tests back, test results back? Anyone want to jump on that?
Sure, I can take it. I agree. It was incredibly frustrating just a few months ago. I had a patient who came to the ER for 2 visits, who separated by 11 days, same symptoms, tested the first time, did not have the results back by the second visit, had to test her again. But also think about how hard it is to do contact tracing when it takes weeks to get an answer back. So anyway, but to answer the question, things are much better now. The speed depends on which test you're running. So we do have rapid tests available. Most of your hospitals are going to have that available now, where you can get an answer back in 45 minutes. There are some that are running faster. I don't know as many facilities right now that are using the 15-minute test, but I think more and more will be. And then the tests, the more in general, the more accurate tests take a little bit longer. So we're kind of choosing which tests to use based on the need for that patient. So the ones that are very accurate, the PCR tests, are done in batches with the bigger machines, and you'd probably get those back in a day or so. So it's much faster now, and you know, I think that the toolbox that we have is also more robust. But it was very frustrating, you know, just over the last few months, where, you know, again, and it wasn't just the test kits, the technology, it was all the supplies, all the components you needed in order to do the testing. We had different issues at different points in the supply chain over time. And you know, that's still, I think, a little fragile, but the test technology itself is better.
For us, it's 48 hours for LabCorp. That's what we're experiencing right now.
I'm going to, because we started a little bit late, I want to ask, and this is a question that probably could take 3 hours to answer, and I'm going to ask each of you to do it in about a minute to 2 minutes. And that is, today is, and this one actually came from Jennifer Lee, Dr. Lee. Today is Juneteenth. How do we address structural racism in healthcare, and how do we eliminate health disparities? And can you do this in a minute and a half, each of you? Why don't we start with Bassem, since you're right in the middle of it?
Yeah, absolutely. I think there's so many pieces to this, right? A big piece of it has to do with trust and outreach, and I think re-examining what one is doing from top to bottom, because I think what happens is people have assumptions that the care they're delivering might be equitable, and that there isn't structural racism even within their institutions, or even in the context that they're offering care in. But a lot of times when you dig beneath the surface, the systems are not meant to help the people who are most marginalized. So, you know, I think there's so many pieces to this, and of course, in a minute, it's difficult to go through all of it, but a lot of it is training, a lot of it is outreach, a lot of it is listening. There's so many different aspects to be able to address this. For us, it's a real issue, because our whole purpose is to serve the most marginalized communities among us. And if we're not able to do that to particular communities, it means that they might not get access to care in general. So it's really important for us. And I don't think one should make an assumption that what you're doing is equitably available for everyone, or that everyone in your organization is necessarily comfortable or feels at home. So I think any institution, even if your mission is in health equity, you should always examine what you're doing and listen and outreach to different communities to make sure that you're reaching the ones who are most marginalized and people who might otherwise not feel like they're welcome or accessing care in a certain setting. And I'm
gonna interrupt myself on this one real quickly, because one question that you can be answered fairly quickly, I think, and is an important one, which is from Elizabeth Flashner again. Virginia will be creating its own health benefits exchange, although I guess we're going to have to see what happens with the budget on that. Some states that have their own exchanges had special enrollment periods in the last few months, but obviously not the federal exchange, thanks in large part to the great leadership in our country. But is there any way that Virginia can open up a special period, even though it currently uses the federal exchange? Can it do it on its own? Anybody have any ideas on that? I think I know the answer to that. I don't see how they can, but
I don't think you can. Yeah, I agree with you, Michael.
Yeah.
You know, my Hail Mary on that, Michael, is one could set up your own exchange, but completely outsource the IT without the costs to using all the data hubs and the APIs that we built. There is a skinny state-based exchange option. I don't know who's working on that one, in my opinion, Michael, but if we're going to have a budget problem, there is a way to do it at much lower cost, but give us the control we need to do exactly what you've said. It's really pathetic that we don't have a special enrollment period at this time. It's just, it's spiteful, it's callous, it's wrong. and we should fix that. And I'm hopeful a budget issue will not get in the way. We can do it at a lower cost, and so let's be all vigilant about it. Maybe just to finish on my sentence on the equity issue, here's where we need sort of structural incentives, and I want to highlight an important point. It is paradoxical that the structural racism and the access problems for minorities and lower income residents, frankly, actually exacerbates the nation's cost problem. When you don't manage a patient's condition and they've got uncoordinated care, well, we have a service, it's called the ER, and a whole litany of things that come from that. So in a bizarre way, doubling down on value-based care, which was a priority in the Obama administration, may actually create the financial incentives to invest in the kind of cultural sensitivity and outreach and programming that Bassem alluded to, not as a charitable, hopeful, unfunded resource that we try to stick in, but built into the business model to say, we've got to find a way to make the uncoordinated, high-cost system that we have with not the best outcomes be more coordinated and organized, and doubling down on value-based care should have that effect. I will also point out, for any physician watching or thinking about their own practice, the challenges of fee-for-service medicine have shined a big spotlight. If you have to shut down the clinic for a month or two, you have no revenue coming in. But if we're moving to value-based care and you had capitated payments, practices that had that kind of capitated payment were able to maintain their staffing, their services offering and everything else, and had a more stable and thoughtful way through this crisis. So I'm hopeful, Michael, we'll double up on value-based care to improve, close some of the inequities that we're seeing on race and income, and then hopefully emerge with a much better delivery system that can be the envy of the world. So Jennifer and Bassem, we're going to build that in Virginia, right?
Absolutely.
That's got to be the last word. But I want to thank each of our panelists and the audience. You guys were fantastic. I think that those folks who attended have a much better understanding of both the problems, and hopefully with people like our three panelists, we're going to come up with some solutions as well. Thank you again.
Thank you, Michael.
And that ends our webinar.